The Positive Pause is a motivational-minded podcast covering topics women want to know about as they journey to and through menopause, focusing on subjects that impact women's health and healthy aging, including what it means to age healthfully. The Positive Pause features experts and influencers from a variety of industries and specialties. The information and opinions expressed on the Positive Pause are not intended to replace the services of trained professionals or to provide specific medical advice. To see the National Menopause Foundation's full medical disclaimer, please visit nationalmenopausefoundation.org.
Welcome to the Positive Pause. On this podcast, we'll share educational, inspirational, and motivational interviews on a variety of topics. I'm Claire Gill, founder and CEO of the National Menopause Foundation, and this is episode 1, discussing women's sexual health at menopause, with Dr. Andrea Singer, Associate Professor and Chief, Division of Women's Primary Care, and Director of Bone Densitometry in the Department of Obstetrics and Gynecology at MedStar Georgetown University Hospital in Washington, D.C. So thank you for joining me, Dr. Singer. I'm happy to be here talking with you about sexual health. The topic of this podcast is got sex. It's one of the questions that come up often for women at menopause about how changes in our body will impact our sexual health, both perimenopausal and postmenopausal. So let's talk a little bit about some of the physical changes that happen to women at menopause that might impact their sexual health.
Happy to talk about the physical changes, but I want to couch that in a little bit of a broader issue because there's so many things that go on around perimenopause and menopause. Changes in life, women may become empty nesters, there may be career changes, then there are all of the hormonal and physiologic changes. So it's probably not just the physical that affects changes in sexual health, but it's really looking at overall status for a woman at the time of midlife. With that said, from a physical standpoint, with decreases in estrogen levels, there are lots of tissues and organ systems that can be affected. And I think one that people often focus on, sort of the genitourinary system. In other words, thinking about the changes that go on in terms of vaginal health, lubrication, changes in local tissues, and things that might make what used to be pleasurable in terms of touch or penetration feel a little bit different.
Yeah, that's a lot of the questions that we get about that. But what treatments are available to address some of those issues that can help women have that healthy, active sex life after menopause or at menopause?
There are a number of things we can do to ensure that women can still have pleasure. And pleasure can be obtained in lots of different ways. So one of the things that we always encourage patients to think about is the broader their sexual repertoire, in other words, the different number of activities in which they engage, the more likely they are to be able to remain active and find things that are still pleasurable if one particular act can no longer be done. So that's something we should be talking about with patients earlier on and then encouraging them to sort of keep a broad repertoire. In terms of actual treatments, we start with non-hormonal options. So vaginal moisturizing or moisturizers, use of lubricants with sexual activity. And then we can also talk about stretching. One of the means by which we can do that is by using vaginal dilators. And then when some of those things may not be enough or may not work, or we need additional options, then we sometimes move on to hormonal treatments, particularly local estrogen therapy. So just to elaborate on some of those things.
Yeah, I was going to say vaginal stretching, I've never heard of, and that alarms me a little bit. So talk a little bit more about that.
Well, we'll get there. Let's talk first about moisturizers, which are generally water-based moisturizers that women use several times a week on a regular basis to help the local tissue, really improve in terms of moisturizing, really bring back some of the natural lubrication that may be missing. In addition to, as I said, those are often water-based. Yeah. In addition to that, with sexual activity, which could be self-pleasure, could be intercourse, could be other forms of activity, we recommend the use of lubricants, right, which may help to replace some of the lubrication that may have decreased with menopause, or just add and ease and reduce some of the friction. Those can be either water-based or silicone-based. The silicone-based lubricants may be a little bit more slippery, tend to stay around a little bit longer, and you may be able to use less of them. And then the whole concept of stretching really has to do with the fact that the vagina is a muscle, right? And if people perhaps have become less active and aren't using that muscle regularly, particularly with penetration of some sort, right? The opening to the vagina can narrow a little bit. And so we want to gently sort of stretch that. Often a woman having control of that, doing it on her own with graded vaginal dilators, one starts small, then can generally increase the size over time so that you could then accommodate a penis, a toy, a something else if one wanted to be sexually active.
And then how is that compared to like the muscle part of it? I mean, to when we're told to do Kegel exercises and things like that.
Kegel exercises tend to be used more to help strengthen the pelvic floor. Okay. We think about them often if women are having urine leakage. Okay. And those are things that can come with menopause too. So when we really think about what goes on in that part of the body, the newer term that we use is genitourinary syndrome of menopause, because that encompasses not just the vagina and the vulva and changes that go on there, but changes we can see in the urinary tract too, and really better reflects all of the symptoms that a woman might have, as opposed to terms that we used to use like vaginal atrophy, which sort of implies nobody wants to think of themselves as atrophic, right? Or aging or with those changes. Vulvar vaginal atrophy is a part of genitourinary syndrome of menopause, but that's really sort of looking at the broader picture. So if women are having problems with urinary continence, with frequent urinary tract infections, there may be specific approaches or therapies that are directed a little bit more at the urinary tract. Much of what we were just talking about really kind of reflects the vaginal and vulvar changes and how we counter that. And those things can be done together. So one can do Kegel exercises and use vaginal dilators as well if there is a multi-pronged approach that's needed.
Yeah, it's really interesting when you think about how much women actually know about their bodies and what's happening to us and our sexual health in general. And I was reading an article recently about a new book that's come out where we're talking about, I think it's like the Vagina Bible type thing is what I was talking about, but describing, again, she wanted it to be the vulva and vaginal Bible kind of stuff, because she was saying that most women don't really realize what the vagina is as the internal organ, and it's actually the vulva that we're talking about when we talk about some of these other things. So there's a lot of learning I think women need to do about their bodies that we probably haven't done throughout our lives. And I think that, menopause is a great time to sort of stop and take stock of all of that and maybe educate ourselves a little better about what's really happening and where and how to address each of those things.
I think that's a perfect comment. And I know this is something we'll get to later and maybe will be a great way to sort of finish up. But often dialogue doesn't go on, right? Women are embarrassed to talk about some of these changes. They're not sure how to ask. Many providers don't bring it up because they're embarrassed. Each party is fearful of embarrassing the other, which is kind of an interesting dynamic when you think about it, because as women and as patients, we should be able to talk to our healthcare providers about things that are important to us. But it's a very difficult topic for a lot of people to navigate. So the more that we can talk about this openly, that we give people the language to use and to understand how to broach the subject if they have concerns, the more what I do in the medical school here at Georgetown is really try to arm medical students with why these issues are important, give them the ability and language to learn how to be able to discuss sex with their patients. Hopefully we can come to a better place and have these be regular discussions that happen so that people aren't seeking advice from it's fine to seek advice from other sources, but we should be able to turn to our trusted healthcare providers as well.
Well, that's interesting because, again, in the survey we did to launch the National Menopause Foundation, one of the questions we asked people was, what is their most trusted source for information? And thankfully, healthcare provider was everyone's most trusted source.
I got nervous there for a moment, so I'm glad you said that.
But who they talked to about it was by far friends, most. friends more than gynecologists, more than significant others. So we're talking with our friends about it, obviously getting information from them. But like you said, I was pleased to see that most people do still believe that their most trusted source for information about menopause is still their healthcare provider. And as you said, we really want to delve a little bit more into that about how to have those conversations. But first, let me talk one more question in general about that. Do orgasms change as we age? Is that how we experience pleasure different physically? Is there any reason it would be different physically, or is that just dependent on the person?
There's so much individual variation in terms of how one responds, and with orgasms in particular. I mean, that's only one piece of pleasure. So I think that's an important message. When we think about reaching pleasure or a satisfying sexual event, it's really emotional and physical satisfaction. Orgasm might be part of that, might be part of that all of the time, might be part of that only some of the time. Even within one individual, the way they experience pleasure can vary from encounter to encounter. So I think first we need to realize that. With aging, there is no age limit for being a sexual being, for being sexual and sensual, or for reaching orgasm. But a lot of these things take people longer. So it may take longer for arousal. Mm-hmm. One may need more stimulation prior to penetration, if that's what one is engaging in, or prior to, manual stimulation or mutual masturbation. It may take longer to reach orgasm. And then that resolution phase, or some people think about it as that refractory period before they can sort of go again, may take longer as well. The orgasms may not be quite as intense in terms of the muscle spasms or frequency, but there is so much individual variation throughout our life that it's hard to characterize it absolutely. If it's okay, I just want to go back to finish up a little bit of the discussion about other ways we can treat the changes in terms of vulva and vaginal changes, because we talked about some of the non-hormonal changes, which there's very little downside to trying most of them, but sometimes they're just not enough. And the beauty is that we have a number of prescription medications or pharmacologic agents that can help women. And when these symptoms are really localized to the genitourinary system and to the vagina and vulva, then we tend to use, if we're going to use hormones, local estrogens. So there are a number of different topical preparations, creams, tablets that are inserted into the vagina, a new insert, a little almost Jelly Belly-like shaped insert that can be used, as well as DHEA that can be inserted locally into the vagina to help really replace what's been lost following menopause when levels are so much lower. And there's also an oral medication called aspemifene, which is a tablet that's taken daily that can also help with some of these changes. So there are lots of options for women, and I think that's what's most important, is that we need to listen to our patients, talk to them, individualize therapy, and figure out, based on their symptoms and their goals, what's going to work best for them.
So let's go back a little bit about the hormonal part. Because when women, I think today, hear hormonal therapy, they get very concerned because of all of the potential side effects there are. The treatments that you're describing that are localized, do they carry the same risks that the hormone replacement therapy does? Is it the same thing? Is this different? Can you talk a little bit about that?
If one looks at the label, it looks like they carry the same risks. There's the same boxed warning on the vaginal preparations or local preparations as there are on the systemic preparations, medications that people take orally and obviously have different levels in circulating in the blood and elsewhere. But the reality is that that's really not the case. And so there have been a number of groups, including the North American Menopause Society and others, that have really tried to get that label changed. You're using a small amount of hormone topically. After an initial induction period, when women start therapy, we often have them use some of these preparations daily for 2 weeks. And then with the estrogen options, and I didn't mention the ring that one could insert as well, but the ring gives a very low dose, steady level of estrogen locally. The other creams, tablets, inserts, women often then tend to use once to twice a week. So the amount that you're dosing is far, far less than anything one would take systemically. As you improve the local tissue, less of it gets absorbed systemically because you've improved that thickness, that barrier, if you will, in terms of the local mucosa or tissue. So we don't tend to see the type of systemic issues either from a nuisance perspective in terms of side effects or from the concern in terms of risk when it comes to cancers that might be estrogen dependent or other things. I think the risks are very small. Nothing is without risk completely. Nothing we do in life is without risk, but I think we can put that in perspective for patients.
Well, that makes sense. I think, too, it's, recent studies have come out again that seem to have confirmed that link between hormone replacement therapy and breast cancers. And I know the Women Health Initiative sort of said that that was really for women 60 and older. But this new study seemed to address more women in general, and that it was a more direct connection to it. So again, I think there's going to be some confusion for women when they're asked about hormonal stuff and they hear hormonal from their doctor. They may not appreciate, as you've just shared, that there's topical and then there's systemic, and then, how do each of those operate differently. So that's great. Let's talk a little bit while we're on the topic of pharmacological treatments. So as we've discussed, there's a variety of reasons and changes that happen at midlife that can affect our sexual health. So including desire and libido. And I know that a couple of medications have been approved by the FDA to treat libido, women's libido. I mean, we all are very aware of what's available for men as far as addressing libido changes. But it seemed that the two that were currently approved were actually approved for premenopausal women who have issues with desire. Now, I would imagine that a lot more women at midlife have those issues than those few that might have it premenopausal. Why would there be a focus on that, do you think, rather than women at midlife?
Hypoactive sexual desire disorder, which is a term that has been around for longer, and we could talk about some of the nomenclature and the way the diagnostic categories have changed, but low desire is the most common sexual complaint that women have, and that is across all age groups. Those who tend to be most bothered by it, you're right, looking at the PRESIDE study, a very large study that was done in women over a wide range of age, sort of from 18 to upper 80s, 90 or so, to try to figure out what bothers women most, what their complaints are, and then who is actually distressed or bothered by it, found that desire problems exist across the lifespan. The group that tends to be most bothered is the midlife women. Women, as they age and go beyond midlife, have decreased desire. But many of the changes that occur, whether it's desire, arousal disorders, orgasm disorders, they sort of expect might happen, right? Because they know they're getting older. Not again that is a given, not that everybody should have to have changes, but they expect that. It's that midlife group who is still very vital, who in some ways sometimes are coming into their own, may have found the right relationship or are comfortable in their own bodies and with their own sexual beings, who now have these changes, and it's distressing to them. So I think that that's a good point in terms of thinking of desire in that group. For the two agents that have been approved, the majority of the studies were done in premenopausal women. Mm-hmm. Now, with flibanserin or Addy, there are studies that have been done in postmenopausal women. It just has not been submitted to the FDA for approval in that age group. But there's really no reason to think that it wouldn't work. And the studies showed that it had the same effects in postmenopausal women as it did in premenopausal women. But at the moment, both agents are only approved by the FDA for use for treatment in premenopausal women.
Yeah, that, again, it just seems to me like another case of something being remiss in helping women at midlife to adjust to the changes in their bodies and focusing on younger women who, again, probably have less distress and less issues with this particular thing, yet that's the age group that gets approved for this treatment. So it's a little bizarre. And I think obviously that we need to do as an organization to sort of help bring about some of those changes where it might be that we focus a little bit more on this enormous group at midlife who are experiencing these changes challenges and hope that we can provide some of that.
The good
options.
news, at least, so the way I would end that section on a positive note is that for the first time, there are options to treat women's desire problems, right? For so many years, it was very difficult to get this even recognized. And because sexual health in women and sexual problems are often multifactorial, meaning it's not just as simple as erectile dysfunction, not to simplify that, and certainly not to say anything negative from talking about male sexual health, because there are lots of issues too. But for women, this is a very complex thing. And for both genders, the focus really now is on sort of a biopsychosocial model or approach to sexual function and dysfunction. So it's not just the biologic or physiologic changes that happen. That all has to be taken in the context of what's going on with psychological health and emotional health, relationship status, the social constructs that we bring to the table, right? People come with religious backgrounds, with cultural influences, with learnings and different education levels from a sexual health standpoint. It's all of those pieces together that affect who we are as a sexual person and affect desire and affect the way we might respond to different treatments. So I think that's the other piece that has always been difficult for women because of the complexities and it being difficult to sometimes isolate a specific cause, then finding a specific treatment has sort of lagged behind as well.
True. Well, we are making progress, as
Absolutely.
you said. So that's good. We just need to continue that progress. So let's go back a little bit to talk about how to talk with your healthcare provider about this. I feel in many ways that some of us live in a bubble where we have friendships or relationship partners who we feel very comfortable talking about our changing bodies and how things are happening, and realize that that may not be the case for many women. But even those who are quite confident and have a good relationship with their healthcare provider still don't know how to broach the subject of sexual health. And many are not going to a female doctor like you, where I think, again, it would be really quite comfortable to maybe bring it up and talk to another woman about it, but that's not a reality for many women in this country. So how would you suggest as a physician that patients broach the subject in order to make their doctor feel comfortable enough to give them the options?
That's a great question, Claire. And I wish I had a perfect answer. I think part of it is incumbent upon those of us who are healthcare providers, regardless of our background, to pose some questions, to have standard questions that we ask of all of our patients so it becomes a natural part of either an intake or a periodic well woman visit or a problem visit, so that the onus doesn't always have to be on the patient. With knowing, though, that this does not always happen, it's important for us to empower women to say these are important issues. And if you have concerns, ask your healthcare provider. The right timing in terms of when to ask during the visit, what wording to use, I think is going to be very based on how comfortable a woman is. But often providers will sort of do what we call a review of systems, where either in a broad sense, they'll say, are there any concerns that I should know about? Or has anything changed since the last visit? Or they may go through a system by system. Are you having any headaches? Are you having any neurologic problems? So that might be a time to sort of be able to say, in fact, I've noticed some changes in my body. I'd like to talk to you about some of these things. For a woman, if somebody is asking specifically about periods, changes in the menstrual cycle around the time of perimenopause, if somebody's asking a woman whether or not she's experiencing any hot flashes or symptoms that keep her up at night sweats, that may be a time to be able to sort of interject that too. The other place could be when you're discussing sort of social history and relationships, right? Often we ask patients, for instance, if I have a patient that I know and I followed for a while, I might ask her about her partner, whether it be a husband or a female partner, might ask about how things are at home. We ask about exercise, we ask about habits. Sexual health should be also, and relationship status should be part of that. But if a provider doesn't bring it out, that may also be a place to sort of say, It's interesting that we're talking about my partner. I actually had some things I wanted to ask you about the relationship going on at home, or about some issues I'm encountering with sexual activity. Just giving women, without even giving them specific words, but letting them know that it's okay to ask about these things, right? That sexual health is actually a right, a basic human right defined by the World Health Organization, that people should be able to be sexually healthy, free of coercion, free of disease. I think sort of extending that, meaning the ability to be able to discuss it and seek care that they need. Oftentimes, it's not that there is a medical diagnosis or problem. There are normal changes that occur with aging that women just need to be able to discuss in terms of how do I manage these things?
Right. I think that's so important. You gave great examples of when we can interject that into the conversation and those questions, how to broach it, because I think that's really what's probably confusing for women. One of the things I was considering as I was thinking through this again, if I didn't feel comfortable talking with my physician about it, and my gynecologist happens to be a man, but he's wonderful and I don't have any issue talking with him. But I was thinking, how would I approach it if I didn't feel that way? And I'm wondering if we spend more time, it seems, with some of the nurses pre-appointment than we do with the physician when they actually come in the room to give us the exam. Is it appropriate to possibly mention, I have some questions for my doctor about sexual health, so that the nurse might put it on the chart, so when the physician comes in, he or she already knows that the patient wants to discuss this? Is that something that's possible? Would it be an opportunity to bring it up to the nursing staff that we feel more comfortable with?
I think that's a great idea. As you said, in many practices, there is staff that will do much of the intake. There might be an advanced practice provider that you will see as well. And you could certainly raise those concerns. So when somebody brings you back into the office and says, what brings you in today, in addition to whatever else might bring you in today, certainly one could say, I also have some questions about sexual functioning or sexual health or menopause or whatever that question is, because that will get relayed to the healthcare provider. And then that may encourage them or stimulate them to sort of think about it if they weren't already planning to ask. I do think we just need to realize that all of this doesn't fall, or the difficulties in conversation don't really fall across gender lines, although many patients assume that a woman is going to be more responsive and able to have this discussion than a man. I really think it depends on the individual provider and their comfort level and what they bring to the table, and also the relationship. What we do know from many surveys, and is important for both patients and providers to know, is that patients are more satisfied with their encounters when all of their issues are addressed, and specifically when sexual health concerns can be easily talked about. So that should encourage people on both sides, provider and client or patient, to have those open dialogues so that they can take care of the whole being, right? The other things we consider sort of in the medical realm, and then patients as sexual beings as well.
Well, this has been terrific, and I really appreciate the opportunity to talk about this, and I hope women will find the information they need on our website to be able to ask good questions, and then also hearing from us about this importance of talking and the right to talk about sexual health is really something that women need to know at midlife so that we can continue to do these. As we wrap up, I know we could talk about, this kind of issues forever, but is there anything major that we've missed that you think women should know about their sexual health at midlife?
I think we've covered a lot of important topics, and you'll just have to bring me back at some point to talk about more. But there are a lot of resources out there, and good resources in terms of what we call bibliography. So some great books that are written by sexual health therapists and counselors. So women should not be afraid to ask for resources or look for them. Don't feel like it's taboo and you can't get the information you need. And I think your website is a great place to start with links to other areas as well.
Terrific. Well, thank you again, Dr. Singer.
My pleasure.
Thank you for joining us for this episode of The Positive Pause. For future episodes, please visit our website, www.nationalmenopausefoundation.org. If you have ideas or topics you'd like to suggest for this podcast, please email us at info@nationalmenopausefoundation.org. Thank you.